Hi guys, we have a case of acute interstitial pancreatitis. I'm going to take it assuming that I don't know the history. Let's just assume that this is a patient that comes into the emergency department with acute abdominal pain. And again, the first thing I like to do is that take 15-20 seconds just to scroll through the images to find out if there's any area that I would want to focus more on. And only after that I do my regular source pattern. So let's start with the lung basis. So right in the beginning, I see there is some pleural effusion on the right side and maybe a small one on the left. And on the right side, we have some atelectasis of the lung base as well. There is some cystic changes in the left lower lung and some in the right lower lung as well. This could be related to smoking, emphysema, or some kind of chronic lung disease. Let's go down into the abdomen. The liver just grossly looks okay. Around the spleen, I do see some ascites. Scroll down to the pancreas, there's a lot of fat stranding around the pancreas, and especially as I move to this direction, there's a lot more fat stranding, probably mainly in this area. When I go to the gallbladder, there is contrast inside the gallbladder. Now, there should not be contrast inside the gallbladder. Anytime you see contrast inside the gallbladder, it's indicative of vicarious contrast excretion. What that means is that if someone's kidneys are not working as well, and if the kidneys are unable to excrete the IV contrast, then the liver excretes it into the gallbladder. So this patient probably had a CT scan, I don't know, a few hours or a few days ago, and the liver slowly excreting over time to the gallbladder. So that's that. So right away, the abnormality that catches my eye is the fatty stranding around the pancreas. So now let's see if so I'll call this acute pancreatitis. So the next step is to see if there's any areas in the pancreas that are not enhancing, because if there are non-enhancing areas in the pancreas, then it would be necrotic pancreatitis. So let's follow from the tail. All this area seems to be enhancing pretty uniformly. There's our splenic artery, calcification in the splenic artery. Right here, as you can see, that's the splenic artery, and we have calcifications there. But as I'm following the pancreas, the duct is slightly prominent, but I think up to 1.5 millimeter is the one reported to be okay. This probably is at borderline. And even when I come down here, I think all of the pancreas is enhancing relatively evenly, so I didn't see any areas of necrosis. The next thing I would like to think about is why does this patient have pancreatitis? Two common causes, one is alcoholic pancreatitis and the other is biliary pancreatitis. Let's go into the coronal images, look at the gallbladder. So there's our gallbladder. Let's see if there's any stone. I'm going to window it heavily, and I do see there's gallstones right there. Let's see if I see any stone in the biliary tree itself. So here we have our cystic duct. Here we have the common hepatic duct. And the cystic duct and the common hepatic duct would make the common bile duct. When I zoom in, I don't see any stones here. Yeah, I do not see any stones here. Now the sensitivity is kind of limited just on CT, but nothing that jumps out at me. And then the other thing that would be important to look at is that it is the intrahepatic biliary ducts dilated, and not really. I mean, no, the intrahepatic bile ducts are not dilated. Now the other thing I like to look at is that it's a case of pancreatitis. Is there thrombosis of the superior mesenteric vein or any of the mesenteric vessels? So here we have our portal vein, left portal vein, right portal vein, main portal vein, splenic vein, follow it out. And this is the inferior mesenteric vein, and in this case, the inferior mesenteric vein joins at the confluence of the superior mesenteric vein and the splenic vein, and our superior mesenteric vein. And when I follow it outside, um, no thrombosis of the mesenteric veins. Now, the other thing I like to look at is let's look at the duodenum. So there is fat stranding around the duodenum. So the primary problem in this case I would call is acute interstitial pancreatitis and this reactive edema around the duodenum. And let's go to lung windows and see if there's any duodenal perforation. No, I didn't see any air around the duodenum. So nothing for duodenal perforation. Let's just quickly scroll down to see if we see any free air. And I'm mainly focusing on the anterior abdominal wall because the air is light and would go up. I didn't see that. Now let's go down. On the right kidney, there's a lot of cysts. I didn't see hydronephrosis or big renal stone. On the left kidney too, we have a bunch of cysts. Like for example, right here, I didn't see any hydronephrosis or kidney stones. Let's go down. Now this is just like fluid tracking down in the retroperitoneum from the pancreatitis right here. There is some fluid here. And there is contrast in the bladder. Now, I know that this contrast is not from the CT scan performed right now. The reason being that right now the contrast is buried in the cortex and maybe making it to the medulla. So remember this vicarious excretion of the contrast I was talking about before. So this patient probably had a CT scan, I don't know, a few hours, couple days before, and it slowly made through the kidney to the bladder, and the kidney was not doing a good job, so the liver started to excrete the contrast into the gallbladder as well. And we get a good look of the bladder here. This person had some kind of surgery around. We see surgical clips. And now I follow my source pattern at this point. And okay, something else that caught my eye is that there's there's fluid in the right inguinal canal, just tracking down. There's no loop of bowel, but just fluid tracking down. And then at this point, I would follow my source pattern, starting with the liver, my hepatic vein, my portal vein, go to the spleen, go down to the adrenals, kidneys, and I would follow each of the ureters down. This is one of the right ureter, and then come back up my left ureter, and then go down and start with the rectum and follow the bowel. This person has a lot of colonic diverticulosis. I didn't see any findings of diverticulitis, like see diverticulitis here, 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 here. This is way too many. And sometimes you see dense stuff in the diverticula. So what that is stool that has remained there for who knows, weeks, months, years, and just the fluid has been sucked out and it's just really dense. Um, so let's go down. So this is just some, probably some contrast material mixed with bowel, because this person definitely has oral contrast. So there's my terminal ileum. There's the appendix. And even though there's inflammatory stranding around the appendix, this is not appendicitis. The reason being that the pathophysiology of appendicitis is something obstructs the appendix and the distal part dilates and there's pressure in the wall and it has ischemia from low blood flow from increased pressure. So if the contrast is flowing freely from the cecum down to the appendix, then at least pathophysiologically this should not be appendicitis. And also the wall seems normal in thickness. There's no abnormal wall thickening. This fluid is just reactive from pancreatitis tracking down the retroperitoneum. And then I would go up, and this person has patulous dilated esophagus. I don't know why, maybe some motility disorder. Um, and then stomach, duodenum, jejunum, and if I want to look at the bowel as a gross, it's much more easier to do it in um, coronal plane just because we see so much of it. So we have loops of jejunum on this side, ileum on this side, and then we can look at the vessels too. So aorta, there's some ectasia of the infrarenal abdominal aorta, a lot of arteriosclerotic calcifications, no aneurysm. Similarly, ectasia of the right common iliac artery, left common iliac artery. There's a small mural thrombus here. It's diffusely calcified blood vessels. And then we can follow the veins as well. Nothing that resembles a thrombus, a right renal vein, left renal vein, a right renal artery, left renal artery. Um, And yeah, I'll follow through my source pattern at this point, but this is a case of acute interstitial pancreatitis, no necrosis. Thank you.